Welcome everybody. Really appreciate you joining. This is one of the ICTC webinar, Knowledge Broker webinars. It's a series that we're running that aims to promote the sharing of ideas and projects and research and learnings from across the global Trachoma program and facilitate constructive conversations amongst ICTC membership. So we're really grateful that you could join, and after the webinar, if you could share this around with your colleagues and friends, that would be much appreciated. Today's webinar, presented by WHO and Tropical Data, will present the findings from a recent study in Ethiopia and Nigeria that tested the integration of uncorrected refractive error coverage, eREC, measurement into trachoma prevalence surveys. This innovative approach taps into existing NTD survey platforms to boost the quality, research and efficiency of eye health data collection and service provision. So we're really excited to hear more about it. The session will highlight three key areas of the study: the methods and results. We'll examine the comparison of different approaches to the measurement of eREC and the findings from both countries. And we'll also be looking into the time and cost implications of the integration, the analysis of how integrating eREC impacted survey logistics and resource use. And we'll also touch a little on feasibility and acceptability issues and hear some insights from the qualitative research, including some interviews with policymakers, health workers and community members. Today we have two fabulous speakers and some other contributors that we'll introduce a little later, but I just want to introduce firstly Dr. Stuart Keel, who's a technical officer from within the Vision and Eye Care program at the Department of Non-Communicable Diseases at World Health Organization in Geneva. His current role coordinates the WHO SPECS 2030 initiative and leads the implementation of the actions outlined in the 2020 World Health Resolution integrating people-centred eye care, including preventable vision impairment and blindness. So thank you, Stuart. He holds a PhD in ophthalmic epidemiology from La Trobe University in Melbourne. Go Melbourne. And prior to joining WHO in 2019, he held positions as principal investigator in ophthalmic epidemiology at the Centre for Eye Research in Australia and was a lecturer within the Department of Clinical Vision Sciences at La Trobe University in Australia. So welcome and thank you, Stuart, for joining. And we also have the fabulous Dr. Emma Harding-Esch, who's an Associate Professor at the London School of Hygiene and Tropical Medicine and Chief Scientist for Tropical Data. Tropical Data is a consortium of partners that provides support to health ministries worldwide to conduct globally standardised, epidemiologically robust population-based prevalence surveys. It supports from the start to the end of the survey process and builds on the methods and technologies developed as part of the Global Trachoma Mapping Project, but is increasingly working on integrating the collection of data with other indicators within standard trachoma surveys. So thank you so much, Emma, for joining and discussing this important topic with us. Just a couple of housekeeping notes. I've also already mentioned that we're recording, so please be aware of that. We'll share the recording afterwards. We are keen to get your engagement in questions and hear for responses from those involved in the research a little later. So the speaker and video functionality for Zoom is on today, so be aware that you can make use of that. So, but also note that we do ask that you keep yourself mute throughout the presentations. And then when you do have questions, you can either put them in the Zoom chat box and I will read them out, or you can, at the appropriate time when I indicate, raise your hand and I'll call on you to answer to ask any questions. And if you want to turn on your video at that point, that would be great as well. And one last note from me, we are running a series of these ICTC Knowledge Broker webinars. And as I mentioned, they aim to promote the sharing of ideas, projects, research and learnings from across the global program, and assist us as members of that program to have important conversations about the issues that are arising and some of the emerging solutions. So we're really keen to hear about what your work is finding. So if you do have something you'd like to share and present, please get in touch with Tim. And please note that the ICTC Secretariat and also ITI will offer support through the process of presenting the webinar. So do reach out. We'll be happy to support you. So without any further ado, I'm going to hand over now to Stuart. Over to you, Stuart.
Yeah, thank you so much, Sarati. So I'll share my slides now. You could just confirm, Sarati, that you can see that okay?
We can see, but if you could put it in, presenter mode, that's great.
Okay.
Thanks, Stuart.
Fantastic. Thank you so much. Great to be here with you today. So as Sarati mentioned, my name's Stuart Keel. I am based in Geneva at WHO headquarters and currently coordinating the work on eye care, vision impairment, prevention of blindness related activities. So my role today is to just briefly introduce this important project that has been carried out, I think, about over the last 2 years or so, that sets out to answer the question. I would make this question actually a little bit broader. Does piggybacking vision indicators or vision-related indicators in trachoma surveys bring efficiencies? So that's what the presentation today aims to provide some answers to, but also this is the first opportunity that we're presenting this information to really start to get feedback from the stakeholder group working within this space as well. So moving now, I just wanted to set the scene. Globally, it is estimated that about 1 billion people have a vision impairment that could have been prevented or is still to be addressed. Majority of these cases, as you can see by this list, could be addressed with very cost-effective interventions such as a pair of glasses or cataract surgery, and also other very effective interventions such as interventions for diabetic retinopathy and glaucoma. So the main point here is to highlight that by far the leading cause of vision impairment is uncorrected refractive error globally across the life course, and that has relevance to the discussion today and the data that has been integrated within the trachoma surveys. So it's clear that the size of the problem is quite large, and it's clear that new strategies are needed. So in line with this, WHO, together with the sector, launched the first World Report on Vision in 2019, which really sets a new eye care agenda for eye care, but really focuses on a comprehensive approach, so integrating all of eye diseases, eye conditions, but also an integrated approach as well with related disease areas, which again fits in with the discussion today. So there has been significant progress towards facilitating the more effective integration of these recommendations set out in the World Report on Vision. At a very high level, there's been very strong commitment through a range of World Health Assembly resolutions, new targets for eye care that I'll touch on in a moment, and also the very first UN General Assembly resolution on eye care that have all been adopted within the last 5 years. And moving on from this, also WHO to support implementation, WHO has developed a range of technical guidance, also initiatives inside and outside of WHO to really support country implementation. And mentioned earlier, one of those is within WHO is the SPECS 2030 initiative that was launched last year. So what's critical in all of this is the generation of high quality evidence to monitor progress towards achieving these recommendations and moving towards this more integrated, comprehensive approach to eye care. So to get a start on this, WHO published the eye care indicator menu, which is the first go at putting together a comprehensive set of indicators to facilitate monitoring of strategies and actions around eye care, both at the national and subnational level, including indicators across the spectrum from input indicators all the way through to impact-related indicators. Within this indicator menu are population-based indicators that are linked to the global targets that I alluded to before that were endorsed at the World Health Assembly in 2021. Specifically, these targets are a 30 percentage point increase in effective cataract surgery coverage and a 40% increase in effective refractive error coverage. The purpose of these indicators are really to be used as tracer indicators to monitor how actions and investments in the sector are really moving towards achieving the goal of comprehensive eye care and increasing quality coverage of eye care. However, this is not without its challenges. There are several challenges to robustly reporting on these indicators, but also on other population-based indicators that are very important within our sector, including prevalence of vision impairment, both near and distance vision impairment, and also blindness, as they rely often, the main source of data to feed into these indicators are standalone eye health surveys. There is a very predominant survey methodology in the sector called the Rapid Assessment of Avoidable Blindness. That's a very standardized, robust methodology in which most of the data for these indicators is produced. However, we know now in the current environment that fewer standalone population eye health surveys are being undertaken due to resource limitations. We also know that based on the current rate of data collection, there's not enough data on eyeglasses coverage and vision impairment. We're really drawing on data from around 70 countries, and this often dates back 15 to 20 years. So really there are some significant gaps here. And one of the gaps is also within age groups. And most of the data that we have for these indicators is in the over 50-year-olds. So we're really lacking data in under 50-year-olds, which is of course very important for eye conditions such as refractive error. So what we have been exploring are new methods to strengthen data on these key population-based indicators. I think it's important to say that no one solution is the savior, but I think that they are all contributing to strengthen this effort. So that's where this opportunity comes in, and this is with the integration of near and distance visual acuity measures within routine trachoma surveys, which, if successful and taken on board in the future, has the potential to lead to improved surveillance and improved evidence-based advocacy on eye care, specifically quantifying more robust prevalence of near and distance vision impairment and more robustly monitoring the 2030 global target for eyeglasses coverage specifically, as it only requires visual acuity measures. And it is a step towards more comprehensive eye care. So these, through these integrated surveys, expanding the scope of evidence, potentially improve planning for eye care services within the populations that are also being served within the trachoma work as well. And this would ultimately drive progress moving forwards for the broader eye care agenda. So with that brief introduction, I'll now pass over to Emma, who will present more on the methodology and some of the key results of this work that's been carried out. So over to you, Emma.
Thanks so much, Stuart, and thank you to ICTC for hosting this webinar. And as Stuart says, this is our first opportunity to share some of what we've done, and we look forward to getting your feedback. So as was mentioned, really the aim of the study was to evaluate the feasibility of integrating eREC data collection within tropical data surveys. And for those who may be a bit less familiar with what tropical data is, we're a service that supports health ministries worldwide to conduct standardized epidemiologically robust trachoma prevalence surveys. And since 2016, we've supported surveys in over 4,000 EUs, or evaluation units, which are generally equivalent to districts, across 54 countries and examining over 13 million residents. So just to give an idea of the kind of platform that this integration could kind of feed into. And so within this particular study, we wanted to pilot the collection of eREC data within trachoma surveys in 2 countries, conduct a cost and time analysis to compare the cost and time requirements of routine and integrated approaches, and explore stakeholders' views regarding the integrated approach in a qualitative study. So the pilot study was conducted between 2024 and 2025 in 2 EUs in each of Nigeria and Ethiopia. as shown in the figure on the slide. And we used the standard trachoma sampling methodology for the study. And we had a separate visual acuity team, which means that the trachoma and visual acuity measurements were conducted in parallel during the fieldwork. And this, in part, enabled the standard trachoma survey methodology of a team being able to survey one cluster in one day of fieldwork to take place. And then, as is routine within trachoma surveys, all data were captured electronically. Next slide, please. So this is an overview of the VA, or visual acuity measurement, the VA measurement was done using peak acuity, and there are members from the peak team on the call if anyone wants to ask them some questions later. The uncorrected VA was measured for everyone, and for those with habitual spectacles, aided presenting VA was measured. And then for those with aided presenting VA less than 612 in both eyes, or those who didn't have spectacles but had uncorrected VA less than 612 in both eyes, pinhole corrected VA was measured. And pinhole VA tells individuals their vision status with appropriate refractive correction. Then, after a brief questionnaire regarding refractive surgery history, a trained examiner measured distance VA for all trachoma survey participants if they were aged 6 years or older. We also compared two protocols for measuring distance VA. The standard protocol, which measured VA at 4 different cutoffs, and then the simplified protocol that only measured if VA was more or equal to 612. Then, after the distance VA measurement, the examiner assessed near VA for participants aged 35 years or older. Next slide, please. So just to highlight how we implemented these two different protocols in the study. So in Nigeria, we performed a cluster level comparison. So one EU was measured using the standard protocol, and then the other EU was measured using the simplified protocol. But then we realized that there could be potential confounding of results because of intrinsic differences between the EUs. So in Ethiopia, we randomized participants at the individual level, so to either the standard or simplified protocols. So then, in terms of the cost and time analysis, we wanted to measure the impact on the routine trachoma survey fieldwork of adding the collection of eREC data. So in terms of time, we used the automatic timestamps from the phones used for data collection to calculate the time taken for the survey. And then to calculate the extra time that eREC added to the trachoma survey, we took the average number of minutes it took to conduct the eREC per person and multiplied this by the number of examined residents aged 6 years and older per EU. Stuart, can you go back a slide? Sorry. Thanks. We then calculated the median time for all clusters in the EU, as well as the minimum and maximum time per cluster within an EU. And to check for consistency with fieldwork, just to make sure that these EUs weren't kind of outliers, we compared timestamps with the most recent previous trachoma survey in the same EU, as well as with other EUs where trachoma surveys were conducted at a similar time as the eREC study, so in different EUs but in the same time period, but by the same team. Then in terms of cost, we used data shared by each country's national programme, and we calculated the cost of doing a standalone trachoma survey, a standalone eREC survey, and then integrated trachoma surveys. Next slide, please. So we considered two different types of integrated approach. So the first one we call separate, and this is the approach that was taken for this study, where we had separate data recorders for VA and for trachoma. And this means that data recording can be done in parallel, so fieldwork can go faster, but it means that there is the need for an extra team member and the need for an extra phone for data collection. Another integrated approach is what we've called combined, where there is a single data recorder for both VA and trachoma. So this means that nothing can be done simultaneously, so the fieldwork would go slower, and the data recorder needs to be trained on both trachoma and VA data collection, so the training will take longer, but it does mean that there's no need for an extra team member or for an extra phone. And in terms of costings and the analysis done there for the combined integrated option, we calculated the cost if a cluster could be surveyed in 1 day of fieldwork, so that's the normal trachoma prevalence survey practice, as well as the cost if the teams had to come back a second day because it wasn't possible for one recorder to do both trachoma and eREC for a cluster in 1 day of fieldwork. Next slide, please. And then finally, to determine acceptability and feasibility of this integrated approach, we conducted a qualitative study in which semi-structured interviews were conducted with different stakeholders. The interviews were recorded and analysed to generate themes of facilitators and barriers of integrating eREC data collection into routine trachoma prevalence surveys. So moving on to the results. So we can go to the population summary, where we see that there were 3,819 participants and 4,290 participants in Nigeria and Ethiopia, respectively. Over 70% of the participants were younger than 35 years, and about half of participants had an education level less than primary school. And in Ethiopia, about 2/3 of participants were female. Then moving on to the main study findings. So first of all, we found that a low eREC value, for example, under the standard VA measurement protocol, the distance eREC was 0% in both Nigeria and Ethiopia. And the near eREC was 0% in Nigeria and 1.5% in Ethiopia. Then second, in addition to eREC, the integrated approach allowed us to assess the prevalence of vision impairment, and we identified a high prevalence of vision impairment, especially for near vision, and nearly 60% of the population had near vision impairment. Then third, we compared those two different vision measurement protocols and found that the simplified protocol was preferred, given that it yielded similar eREC and prevalence of vision impairment results, whilst taking less time and being less tiresome for participants. Then fourth, our cost analysis revealed that compared to doing separate surveys, the integrated approach could save both time and money, and I'll go into that in a bit more detail in a minute. And then finally, the integrated approach received positive feedback from different stakeholders during interviews, and we'll discuss that a bit more later as well. So going into the time analysis in a bit more detail. So these are the results from Ethiopia, and the two rows in bold are the results of the two EUs included in this study. The row underneath each of those is the comparison of the standard trachoma survey in the same EU in the most recent survey. And then the last 4 rows are other EUs where there were trachoma surveys conducted at a similar time by the same teams as those time periods. So just to have that sense check of these EUs. And based on the data, these data from Ethiopia, the median data collection time for an integrated survey, so the combined approach, where a VA and trachoma data are collected on one phone by one person, adds about 2.5 hours to the trachoma survey time per cluster. And the overall median time ranged from about 6 to 10 hours across the different EUs where the timings were applied. And this is just the fieldwork time. It doesn't include the travel time or provision of eyeglasses or referral. So in Ethiopia, whether it's possible to survey a cluster per day using this combined integrated method will depend on the time to travel to the cluster and the setup in the cluster. So for example, distance between households or household size. Moving on to Nigeria, again, the two rows in bold are the two EUs included in the study. The rows just underneath are the same EU, the most recent survey that was trachoma only, and the bottom two rows are surveys conducted by the same teams at the same time, but different EUs. And here, because we compared the simplified and standard protocols at the cluster level and at the EU level, we can see that the top row used the simplified protocol and the second bold row in Kaugama used the standard protocol. And so when we did the comparisons of the costings, we've done and the timings, we've done a comparison of how much time it would take using the simplified protocol applied to the different EUs and how much time it would take using the standard protocol applied to the different EUs. So they're the different kind of columns in this table. And so based on these data from Nigeria, the median data collection time for a combined integrated survey with the simplified protocol was about 5 to 6.5 hours. So adding eREC added about 3 hours per cluster. Whereas for the standard protocol, it was about 6 to 9.5 hours, adding about 4 hours to the trachoma survey. And again, this doesn't include the time of travel to the cluster or provision of eyeglasses or referral. So looking at the simplified protocol, it seems that actually it's possible to survey a single cluster in 1 day of field work, even if it's a single data recorder for both VA and trachoma. For the standard protocol, it's going to be more context dependent and going to depend on things such as time to travel to the cluster and the setup in the cluster itself. Then moving on to costs, reiterating that these were data shared by the national programme, so they're the programmatic data. They're not data collected as a kind of research study, so they're not as detailed, and they don't necessarily between the two countries have the same kind of budget lines. So don't look at the absolute costs, but more the relative costs between the different survey types. So using the data shared by the national programs, we calculated the costs in US dollars of what a standalone trachoma survey would cost, a standalone eREC survey would cost, then the total cost of those, so one added to the other, so that's the total of the separate trachoma and eREC surveys. And so this is the comparison against which to compare the cost of the integrated combined survey. And there we've done the costs of 1 day per cluster or 2 days per cluster, and then an integrated survey using the separate approach where you've got a separate data collector. So the teams working parallel like we did in the study that we conducted. And the key takeaways are that compared to that total or separate trachoma and eREC surveys, the integrated approach in general has cost savings in terms of, for example, being able to combine community sensitization costs, reducing trainer logistics. So for example, travel to the training venue and the survey types can be shared between trachoma and eREC. And there are also reduced survey costs. So for example, in the combined approach, you can have one fewer team member, and there are shared costs such as supervisors and local guides. And then if it's possible to survey 1 cluster per day, which is the standard trachoma method, the combined approach has the overall cost saving of an extra day of field work per cluster. And then for the separate approach, although there's an extra team member, the survey costs less because it's possible to do the field work for both trachoma and eREC in 1 day, and the training cost is reduced because the 2 different data recorders can be trained in parallel, cutting a day off the training agenda. Then finally, moving on to the acceptability and feasibility results, we generally receive positive feedback. So in the orange-pink box at the top, the respondents thought that adding VA measurement into the routine trachoma survey was beneficial for the study participants and provided a great opportunity for resource sharing. Then in the green, the feedback was though the standard VA measurement protocol might theoretically be more accurate, the simplified method was more welcomed by the participants and data collectors. And then in the last two boxes, a key piece of feedback was that the inability to provide on-site refractive error correction was a major challenge, and there needs to be clearer guidelines relating to this for the future. So there are several considerations stemming from this study. So first, we identified a huge need for refraction correction. And we assume that the low eREC plus the high vision impairment is likely to apply to many other countries in which trachoma surveys are carried out. Second, the integrated approach showed clear benefits, including an opportunity to save time and cost through resource sharing, and this helped trachoma survey participants to better understand their overall vision conditions. But there were several challenges that we should bear in mind for the future. So one is coordination. So there needs to be a clear coordination between the trachoma and eye sectors, which could be overcome by careful preparation and prior discussions regarding budgets, logistics, and data management. And also the choice between whether a standard or simplified protocol should be used needs to be decided based on the specific situation and context. And then the final key point is the importance of being able to provide reading glasses to those in need during the field work. So in this study, because of time and funding issues, we weren't able to provide reading glasses in the field, and mostly just referred patients for management. And we would strongly suggest that future studies deploying this integrated approach plan for and implement this. So just to finish off, a huge thank you to the whole study team. This was truly a team effort, and very importantly, if not most importantly, to the field teams and the community participants, and to CEBM for funding WHO for the work. And thanks everyone for listening. And I'll now pass over to Sarati, who's going to lead some moderated questions with some of the study team members.
Thank you so much, Emma and Stuart, for that fabulous presentation. Yes, we're going to now kind of direct a couple of questions to the field teams and implementing partners, and then open it up for some questions. So my first question to the field team. So Caleb, if you're online, and then Elamu, if you are also online, I'll get you to jump in after Caleb has responded to this first question. But Caleb, I'm wondering if you might share your general experiences from the field. What went well? What were some of the practical challenges that you encountered? And in relation to those challenges, how did you overcome them? It'd be great to hear.
Well, thank you very much. It was clear that we could definitely be able to measure visual acuity when we are conducting trachoma surveys, and be able to do that within the 1 day of handling a cluster. That worked very well. And I think for many of the children, they were very excited to get their visual acuity check. I'm not sure whether they were much more excited about knowing their visual status or excited using the phones, which is something they had not seen before, to be used to check their visual acuity. But at least that gave us opportunity to check visual acuities of everyone that was there. So they very excited about that. So in that aspect, it worked well. But of course, there was the fact that it took much more time to check visual acuity than the examination for trachoma. So it means that the visual acuity teams delayed a bit the work of the trachoma teams. But on a general basis, they were able to work together and get households and clusters completed within the time frame. One other thing that I think also increased the time for the visual acuity teams was the fact that we measured GPS for every person we actually examined, while the trachoma teams only measured for households GPS data. And I think maybe going forward, if we want to do that, is something that we want to use what the Trachoma teams did, just measure GPS data for the household. And that would also reduce the time that would be spent measuring visual acuity. I think I'll stop there and hand over to my colleague from Ethiopia to add some other points.
Thank you, Caleb. I am Alam from Ethiopia Freedom Foundation. You know, during the survey, the Freedom Foundation team and the Oromia regional team plus the zonal team had been working together to attend this experience, this survey, because it's very new. So we have seen, you know, a lot of strengths as contributing to the Trachoma impact survey and also the eREC survey. The first, you know, important value that we have seen is that both teams had been working simultaneously on, you know, different problems. On the first day, of course, there was some you know, lack of collaboration between the two teams, but on the second day, we have seen that, you know, very smooth collaboration and working environment after learning from the Trachoma impact survey. That was the first thing. And the other is, you know, we were also able to maximize our resource. For example, we have used only one vehicle for one team. When I am talking about one team, the Trachoma team and the eREC team had been, you know, using one vehicle, which is a very good advantage from this integration. And the other is we have used also, you know, one coordinator and one guider for both teams. And that's also another advantage that we have seen from this. I think the reading eyeglass distribution could also be, you know, possible, but unfortunately we use that opportunity, but that's also another, you know, another advantage. And of course, there are some limitations like, you know, waiting time. For example, if the Trachoma impact survey completed its assessment and the eREC survey has lagged behind, then there should be a waiting time to, you know, wait one another. And that is also one of the limitation. And the other limitation that I would like to maybe mention here is, you know, in case there is uncorrected refractive error, which requires, you know, like refraction and different types of, you know, examination, then there should be a referral linkage with some eye health facilities. And of course, we have, you know, linked the team with the nearest secondary eye care units. I think these are the limitations that I have seen. Back to you, Sariti.
Thank you so much, Elamu and Caleb, for those responses. I now have a question for the qualitative study team. So if Tosin and Jaffa have some responses they'd like to add to this question, that would be great. What were some of the general reactions to the integrated approach from different stakeholders that you interviewed? And was there anything in particular that stood out or surprised you?
Sarity, I'm not seeing either of their names on the list of participants, so I wonder whether maybe they didn't manage to get online. Apologies.
Okay, thanks, Emma. Perhaps we'll engage them later then. I might then skip then to Beatrice from FHF. Beatty, would you be able to perhaps provide some reflections on, from a strategic perspective, what you see as some of the key benefits of integrating eye health indicators into a trachoma survey, and any insights or considerations for the sustainability of the approach for the future?
Yeah, thanks, Sarity, and thanks, Emma and Stuart, for the useful presentations and the insights, Caleb and Alamu. I think it's really great to get to this point where, can you hear me okay? Oh, sorry, I just had a
Yeah, we
message.
can. Go ahead.
Yeah, sorry. I think it's really useful to get to this point where we're able to do these comparisons and get these insights into how effective this survey approach and sort of, the rollout of this project has been. I think there's clearly benefits and particular benefits in certain elements of the project, like the simplified protocol, as Emma highlighted. I think from a strategic NGO perspective, it's really important that we carefully consider the implications of these these results, particularly on not just survey, but also program planning. So, at the Fred Hollows Foundation, we're really big believers in no survey without service. And I think given the geographical distribution of some of these people and the high refractive error rates, it would be really important to consider how we can start to plan and coordinate both budget and procurement factors to include at least ready-mades and if not ready to clips for children when survey teams are going out. I think providing those visual acuity assessments is useful, but the referrals are at times a bit useless if there's no kind of feasible and affordable follow-up alternatives for people. So I think we have a real obligation to think through that carefully. And the last point I'll quickly make, just because I can see we're running out of time, is that I think it's great to see these results using the peak technology. It really shows an effective approach to collecting and capturing that data and using it to drive study results like this. So it was great to see that in play. Thanks so much.
Thanks so much, Beatty. So we have a couple of questions that people have popped in the chat. Thanks, Martin, for your question and that point around the importance of no survey without service. I think Beatty and Elamu have covered that a little, so I might jump to the next question just because we are short on time, and then circle back if anybody wants to add any further points on that question. But Sheila's got a question in the chat just around how WHO feels about the survey that largely represents families with children aged 1 to 10 years, and how do you then characterise the findings? So I know you began to pop a response to that in the chat. Did you want to verbalise that a little further and clarify?
Thanks, Arity. It's perhaps more for Stuart to respond, but at least my understanding is that the standard survey protocol for trachoma is to select all households in the identified compact segments. I think that's the approach that was used specifically in this study. Emma, is that right?
Yeah, that's correct.
Yeah. So it isn't a case that that households with children are preferentially selected. But I wondered if Sheila was actually asking more about sample sizes than a kind of bias in selection.
Sheila, did you want to clarify your question? And then I might see if Stuart has anything further he'd like to add.
No, I just wanted to hear Stuart's comment on how he would characterize this, given that the concern was about RAB, which largely focuses on older adults and is a random sample of people. So I just would like his response to how he interprets the findings out of this.
Yeah, I think we're still unpacking it a little bit, Sheila. But on one hand, of course, there is this added benefit that we are getting some data in the younger population, which we don't have a lot of. So any strengthening in that regard is great. We know that based on the natural history of refractive error, it's normally, we're not going to see much before 6 or 7 years of age. So that was taken into consideration in the inclusion criteria for the visual acuity measures as well. But certainly something to unpack and look. I mean, we didn't present specific age group results in detail during the discussion, but it's something that we can certainly do in the future and unpack this a little bit further. If I could, Sarity, I'd just comment briefly on the fact that many people have mentioned about the service, the post-service, and one key area and potentially addressable area is with the reading pair of near vision glasses. I think this is an area where, with minimal training, they can be sort of provided at the point of the survey. So we have considered these solutions, and we also have, of course, each NGO has their own potential way through this, but we also at WHO have been engaging with the key industry responsible for manufacturing these glasses, and certainly there is interest to support these endeavours moving forward. So that is one that I would be confident. I would hope that we could address that particular issue around providing near vision spectacles in the future.
Wonderful. Thanks so much. Another question in the chat, and perhaps this is for you, Emma, to add to and provide some clarification. Did the survey team complete one cluster per day for both Trachoma and eREC survey, or did the clusters take more time than usual for the Trachoma surveys?
Yeah, so thanks for the question. Because we had the teams working in parallel, it was possible for the teams to do one cluster per day in terms of the field work. So when we were doing the analysis, we were just adding on, using the data from the eREC data collection, how long it took per individual, and then adding that on to what the Trachoma time was in terms of trying to assess how long it would take if you just had the one individual doing both data collection for VA and Trachoma. And then I was just going to add on a tiny bit more about the provision of glasses and a comment that Alamu made about the speed at which the teams work. So if you do have the teams working in parallel, and if one team is working faster than the other, it does provide that opportunity for the waiting team to do that provision of spectacles and to have that kind of management whilst they're waiting. So it potentially, if you've got the two teams working in parallel, you can do both in one day of fieldwork. But definitely the time taken to do provision of spectacles would be something that needs to be added in to that overall time in terms of fieldwork.
Wonderful. And Emma, if you could stay on and just respond to this last set of questions before we wrap up. Was there any improvement in the timing of the vision tests during the study? Was there possibly a learning curve effect at all that you observed? And did the screeners have similar levels of experience with the vision testing as they did with the Trachoma surveys? And the last question is were there any particular reasons for the difference in the costs between the two countries?
In terms of timings, I'm actually going to throw this question to Chrissy, who I knew it was coming his way because he did the timing analysis and he knows in depth the differences between the different screeners. Sorry, Chrissy.
That's okay. I just did that analysis because thank you to Marcia for putting that online. Yes, I think there is. I haven't put any statistical tests on it yet, but at the start of the 10 days that they were in the field using either of the two protocols, they were taking about 30 seconds longer per person than at the end. So there is definitely a training effect. But, I would need to put proper precision estimates on that to be able to say that that's a robust and demonstrable fact. But yeah, I think it's pretty clear that they get better with time and they get quicker with time.
And then in answer to the final question, there were differences in terms of the size of the teams. So Nigeria were training much fewer number of individuals and had fewer kind of teams going out versus in Ethiopia. And also the composition of the teams was a bit different. So for example, in Ethiopia, and for example, in terms of the trainings, they had more different types of trainer than there were in Nigeria. So there were differences in terms of kind of how the programs were deployed in both countries.
Wonderful. So thank you. I think that brings us to time. I just want to again thank Stuart and Emma for their fabulous presentation and to all the teams involved in both the execution of the study and the analysis and write-up and for answering some questions today. This is an example of a really important collaboration between different NGOs as well as between different sectors. If we look at kind of the collaboration between the NTD work here, Trachoma work here and the eye health sector. So fabulous, and it's great to be able to share this with the broader ICTC membership. So I'd just like to end by encouraging others to step forward and share their work. We would love to hear what's going on and work together to really find innovative solutions to some of the challenges that we're encountering as we reach the last mile in relation to trachoma elimination. So thanks again, everybody, for joining. If you do have something you'd like to share, please shout out to Tim. Tim, I don't know if you want to pop yourself on camera briefly and say hi. But Tim, would really love to hear from you, and we'd love to support you to run a webinar like this. So thanks, everybody.
Thank you, Sarah.
Thank you.